Hi, Dr. Manhapra, yes.
Are you still there? Okay.
I am
Make
still
sure
here.
that my line is active.
We're still going to get started, everyone, in just 2 minutes. Hello, everyone. We're going to get started today. Welcome to the webinar, Creating Protective Environments for Service Members, Veterans, and Their Families, Factoring in the Role of Managing Pain and Addiction, presented by SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center and sponsored by the U.S. Department of Veteran Affairs. This webinar is session 2 of a 3-session suicide prevention virtual event series and is being offered as a part of the SAMHSA VA Mayor's Challenge to Prevent Suicide Among SMVF, which is a national initiative focused on engaging local communities in a comprehensive public health approach to the prevention of suicide among SMVF. We can move on to the next slide. So I'm Angela Wright, the Assistant Director of SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center, and I will be moderating this webinar. Before I introduce you to our esteemed presenter for this session, I would like to quickly go over the objectives for this webinar, explain a little bit about the agenda going forward in this next 2 hours, and provide a few housekeeping notes. Okay. So the objectives for this webinar are to provide an overview of the characteristics of chronic pain among service members, veterans, and their families. You'll see the acronym SMVF throughout the document, and we use that consistently throughout to mean service members, veterans, and their families, and to be inclusive, both active duty and Guard and Reserve members, along with their family members and veterans. We will explore the relationship of chronic pain and addiction, also define an SMVF person-centered protective environment in relation to the CDC technical package, which we can provide a link to at the end of this session. The technical package goes over specific strategies that are evidence-based to prevent suicide among this population. Describe what is needed to create a protective environment for SMVF in your care, and we'll discuss available resources for veterans and families to minimize suicide risk. 2 hours, we're going to break this up into 4 parts. We keep this interesting and interactive for all of you. The first part is going to be an overview of chronic pain and suicidality. We're going to kick off the first part with a poll question, and you'll have a little screen pop up in your screen, a little box pop up in your screen for you to answer the question, and then we'll display the results to everyone so we can kind of gauge everybody's at on the questions. Then Dr. Manhapra, our presenter, is going to give his presentation for about 20 minutes, then provide a quick Q&A session. These Q&A sessions are pretty brief, about 5 minutes, so we'll be able to take about 2 questions for each part. We're going to go over the understanding of chronic pain to prevent pain-associated suicides. We will do another poll question and have a presentation and then repeat that question, kind of a pre-post test kind of situation where we see where you're at when we begin the presentation, and then we'll see where you're at after you hear the information. And then we'll give you a chance to ask a couple of questions. The third part, we're going to talk about understanding pain and opioids. Again, do a poll question, presentation, Q&A format. And the last part, we'll do a presentation about understanding the dynamics of addiction, and we'll have the last portion with Q&A, and then we'll wrap it up at 4 o'clock Eastern Time. So just a couple of housekeeping rules. We have a chat box on your screen to the right-hand side. Please use that to introduce yourself and to connect with one another throughout the presentation. Any questions for the presenter, we ask that you enter those questions in the Q&A box. Myself and our project assistant will be monitoring the Q&A box, and we'll develop those questions to our presenter during the Q&A period for each part of the session. And a common question that's always asked, I just want to throw it out there up front, is that we will be providing the full deck of presentation slides to everyone via email after the webinar is over, and we are recording this webinar as well. So with that, I would like to introduce you to our presenter, Dr. Ajay Manhapra. He's an internist and an addiction medicine specialist. In this role, he runs the Advanced PACT Clinic at Hampton VA Medical Center, which provides comprehensive whole-person care for patients with complex, severe, disabling pain and multiple other problems, including addiction, medication dependencies, psychiatric disorders, and medical illnesses. Dr. Manhapra has research and academic affiliation with New England MIREC and Department of Psychiatry at Yale School of Medicine. Research is focused on substance use disorder and comorbidities, engagement in buprenorphine for opioid use disorders, pain, and addiction. Dr. Manhapra is currently focused on developing primary care-based comprehensive treatment paradigms for complex chronic pain patients, especially those with addiction and mental health disorders. So I'm very pleased to introduce you to Dr. Manhapra, and I think he's going to be delivering a really great presentation. I've seen it. So I turn that over to you, Dr. Manhapra. We'll start with our first poll.
Angela,
I'll give you the control of the slides now, too.
So forwarded on the top, right?
There we go. Yep, just the arrows on the top right. Yeah.
Okay. Here's the first poll question. Approximately what % of adults who die by suicide have a pre-existing mental illness? Just idea of, what I think is the approximate number or percentage. 90, 80, 70, 60, 50, less than 50.
Okay, we'll be closing the poll in about 30 seconds, and we'll show the results. Okay, closing the poll.
So,
All right, go.
So I think a lot of people, a lot of people thought it was, that percentage is 70, 80. So now let's look at the data here. So this is the recent study that came out of, CDC looking at the suicide patterns here. So you can see that, 54% of more than half of the people who died due to suicide did not have a known mental health condition. So suicide is more than a mental illness problem. In this population, around 20% of those without mental illness and 15% of those with mental health conditions were veterans or active military personnel. So, but actually, the population of U.S. adults, veterans, is about 8% of the total adult population. So there's a higher percentage of mortality, and this pattern really follows up in veteran data too. The most suicides, you don't detect a mental health illness. So, a few more factors regarding. There's many factors contribute to suicide. Relationship problems are the most common. Then there's crisis in the upcoming weeks, criminal legal problems, loss of housing, job, financial problems. And there are problems that we are going to concentrate a little bit about, problematic substance use, physical health problem, which is pretty common. In the veterans, it's even more common. And we'll focus on that during this presentation. And physical health problems includes chronic pain. So we'll how each of this plays out and the interaction plays out a little bit. So here data from that CDC study. There are no health condition, non-mental health conditions. Without mental health condition, mostly male, and they mostly die by firearm injury, or more commonly with firearm injury, and less of poisoning compared to people with mental health conditions. Mental health conditions, there's a little bit more of females involved. Surprising facts. About 55% of deaths among 45 years or above. There's also prior research showing that increased suicide suicide is increasing among middle-aged individuals. Only third has current depressed mood, and few closed intent. Few had known suicidal, and few had prior attempts. So this is vastly different from what I knew about suicide when I was not that interested in suicide. Now I'm more interested in suicide, so now I know a lot more about it. I recognize this, but before this is a common perception that it is just a mental health issue. VA data from the VA health autopsy study, the most common risk factor stated is pain. Then comes unsecure firearm, then health problems, relationship problems, hopelessness, decline in personality, which commonly occurs in pain, financial loss or strain, which also is got a high association with pain. So the mental illness comes way down the risk factors that is considered for suicide when we actually look at the data. Again, here only 13.8% has severe mental illness. This VA behavioral health autopsy happens every 4 years. They go through every suicide in a year, do extensive chart review and even family interviews and all those things, and goes through in detail this data from that. Substance use in 10%, no known factors in 29%, physical problems in almost 10%. So it's a much complex issue than what we perceive as a simple, as a straightforward mental health issue. This is why, as an internist, I get interested in suicides quite a bit, because a lot of my patients have suicide thoughts, and so they have committed suicide. So let's look at the literature to get a perspective of what's the difference between pain, substance use, and other health problems with suicide. Here's a study from Veteran Health Administration by Ilgen of University of Michigan. So he found that most types of pain associated with higher unadjusted risk of suicide. But when you adjust for psychiatric problems and demographic features, back pain and migraines is strongly associated with suicide. And most of the deaths among these in pain patients were due to firearms, much more than seen in the general population, and poisoning. The other means were less often seen. I looked from the in a cohort of patients. What is the prevalence of this behavioral equivalence? So about a third or more has death wish. This kind of approximate calculation based upon this paper. Live suicidal ideation is about 20%. Current suicidal ideation is about 8%. Current suicidal plan is about 2 to 3%. and about 3% have attempted suicide recently, and death rate is about 0.5%. All these numbers are substantially higher than seen in the general population. So chronic pain is associated with quite a bit of suicides if you really look into it. So let's help to get a perspective of influence of other illnesses. Let's look at healthcare utilization before suicide. This is a study from a major integrated healthcare system like Mayo Clinic, Henry Ford Health System, and all those things. All similar health systems. Kaiser Permanente is involved in here. So from an insured population who committed suicide, so 83% had a healthcare visit in the year before, and 50% in the 4 weeks before suicide. Most visits were primary care visits without a mental diagnosis. What this tells us that the prominent problem in a substantial proportion of these patients is physical health issues, and mental health visits were low. Inpatient mental health was substantially lower. Even those with mental health, only less than half, about half had a mental health visit in the past year, and it does not it's not appear, at least from the this observational data. It is not the predominant issue in these people which they have to deal with. So there's another issue. That doesn't mean that mental health is not an issue, but in most suicides, the physical illness seems to, at least a substantial proportion of suicides, physical illness, disability due to physical illness seems to dominate quite a bit. So another case control study, which was more recently, from the same data sets that we saw before, 9 common physical health conditions associated with higher risk after adjustment for sex, age, substance use disorder, and mental illness. About 2/3 of those people who died had one of these conditions, and about 40% had more than one conditions, which we call as multimorbidity, and one chronic condition interacting with each other. Only in the people who did not commit suicide, only 36%, on a third had one of these conditions. Only 20% had more than one of these conditions. So there's a substantial difference between people who committed suicide and did not commit suicide. Brain injury, which is pretty common among, not pretty common, which is frequent among veterans, and multimorbidity had very high risk, adjusted risk of 8.8 and 4.1. And they also described that sleep disorders is common and was associated with substantial risk. And another study looking at this, this is an older study from Journal. This is the number of illnesses that people have. This is this axis is the estimated relative risk of suicide. As the number of illnesses goes up, the risk of suicide also goes up. So there is a definite connection between these two. So physical conditions, which physical conditions are commonly associated with suicides? Chronic pain, traumatic brain injury, congestive heart failure, COPD, cancer, epilepsy, migraine, sleep disorders. These are the major conditions that are associated with suicide. So now shifting gears a little bit, substance use disorder and suicide. Substance use disorder is associated with 10 times higher risk of suicide. Association is stronger among women, but more suicides are among men. Specifically in substance use disorder, there is a stronger association between substance use disorder and suicides among women more than men. Alcohol is the most studied. Alcohol use disorder is associated with 10-fold increase in risk. Acute alcohol intoxication is also associated with increased risk because it causes psychological distress, aggressiveness, impulsivity, and constricted cognition. Opioid and cocaine use disorder, there is less data, but the association in the studies that we have, there's a strong association. More importantly is this polysubstance use. People who use multiple substances, like alcohol and opioids, alcohol and cocaine, or alcohol, cocaine, and cannabis. These people have substantially higher risk of suicides and also overdose. We'll touch upon that data a little later. So in these people, the same risk factors appears to operate, which we see in the larger population, which is depression, light stress, physical illness, and relationship issues. In this set of people, these risk factors seems to play an additional role too. So this looking at the first suicidal attempt among people who entered a substance use disorder treatment. Again, here, three things pan out: is health-related work impairment, that people have health issues and they cannot gainfully employ themselves, suicidal ideation, and childhood physical abuse. Depression is not a predictor of suicide attempt, was but a predictor of suicidal ideation. We see this in a lot of data sets, the same finding. Depression has got more association with suicidal ideation than attempt. Another study looking, opioid use disorder is the predominant problem in the society now. Looking at opioid use disorder and suicides. Again, this is an 11-year follow-up study from, is the longest follow-up study from Australia. They reported 42% ever having a suicide attempt in that 11 years. 18% had multiple attempts. 10% had reported current suicidal ideation. 4.2% has reported current plans. And these are markedly higher rates than you see in other populations, or general population. The predictors, other predictors in this population, again, is the depression, polydrug use, poor physical health. So this, if it is people under treatment, this changes into polypharmacy. We get multiple medications for different psychological and psychiatric issues. Opioid misuse, which is a big topic now. Again, the same picture. Prescription opioid use weakly associated with higher risk, higher the frequency of misuse, the risk. Again, poor health, past substance use disorder, depression, predicted risk. So there's a trend of these three or four factors coming up again in different populations. So, in summary, suicides are more than a mental illness problem. Just focusing on mental illness is to address a substantial proportion of people with suicides. So we have to have additional focus on non-mental health factors like physical health issues, which is debilitating and which prevents people from attaining full functional life, relationship issues, lifestyle, substance use, polydrug use, or CNS polypharmacy, that is multiple medication which induce sleep, which are psychiatric medications mostly, which is sleepers, psychiatric medications, pain medications, and other CNS medications. So when you're approaching the suicide, what data advises us, is you have to approach the whole person, not just the mental illness. So in the next two parts of the presentation, we're going to take pain and addiction, try to look at pain and addiction in a comprehensive way, which you can use in other situations too. So, all right, I'm with this part of the presentation.
Dr. Malhofer, thank you so much. This is Angela Wright again, and I want to just say thank you for presenting all of the statistical information. It can be quite overwhelming to everybody, but hopefully with the visual it was easy to understand. We just have one question in the Q&A box, and they were asking about statistics based on sex, race, and culture. And I didn't know if you had anything in your back pocket to speak out to that, or
so the overwhelming statistical trend in this population. In the sense that the suicide thought, ideations, and attempts are more in women mostly, and suicide completed suicides are more often in men. Mostly, I think this is my speculation. Mostly is because they use firearm for committing suicide than the women population. Again, in substance use disorder and pain, it's predominantly men population more than in general population, more in white population than in Caucasian more in Caucasian population than African Americans or other races, related to pain, and substance use disorder too, mostly in Caucasian population, slightly, but no population that is not vulnerable to this risk. And in substance use disorder, this risk of, the absolute numbers are larger in, men. Most people who has substance use disorder and suicide are men, but women have, more risk. They seem to have we commit suicide seem to have a higher proportion of substance use disorder than men. That is much the succinct data that I can provide there. I don't know. I have not looked into that too much.
Dr. Mahabra, I think, well, in the interest of time, keep moving forward and deeper, and I'm sure that there'll be a lot more cut in the Q&A as we get into this further. So I think the next part is understanding chronic pain to prevent pain-associated suicides. And I'll hand the ball back over to you, Dr. Mahabra, to introduce this next poll.
This is point two. This has two parts. So this, just to what is your understanding of pain? So pain. How much do you agree with each of these following statements? Pain is generated at the site of injury or disease and then sense pain, and you have two options. You completely agree, B somewhat agree, C somewhat disagree, D completely disagree. And question, chronic pain is usually due to persistent injury or disease site of pain. Yes, completely agrees, somewhat disagrees, completely disagree.
In about a minute to answer this poll. It's a little bit more of a complex two-part question, so we'll give you a little bit longer. And remember that this is going to be a two-part. We're going to ask you what you think now, and then after Dr. Mahabra's presentation, we'll ask you what you think again. Okay, we're going to go ahead and close the poll in about 15 seconds. All right, the results should be showing on your screen.
Yes, people think, somewhat agree to this, So let's look at the pain. This might sound, the pain might sound a little complex to a lot of people, but this is a conversation which I have with my patients who in my clinic. So none of part of this talk is overtly complicated, but it takes a little time to digest it. So just I like to go very slow with this. So, we mostly see pain as a sensory experience, but it's a complex brain-generated psychomotor experience, which we technically call as behavior in psychological science, which involves cognition. It's not just an indicator of injury. Pain is part of a larger brain-related behavioral response suite, promotes healing and protection from harm and survival. So we'll go through these two factor statements in detail over the next few slides. Why do you need to understand pain? That's the question, because why this doctor's issue, right? No. I mean, if you have to really help these people, you have to understand the suffering and help them, help make meaning to their suffering. And if you are in policy development, if you are in implementing processes for pain, suicide prevention, you to have a basic idea of pain would be really helpful. how people we like to think that doctors are objective people who think in a very structured way. No, that's not true. We are like everybody else. We like stories. We create stories about particular illnesses in our head, and which we share with the patient. So patients have a narrative, clinical narrative regarding for any illness, which is they get out of their healthcare providers. So what is the conventional pain narrative? That the acute injury causes pain at the site of the injury. So if you have a knee fracture, the pain is created at the knee. The brain senses the pain, creates a distress, and the physical disability is mostly a local phenomenon with some contribution from the brain. This is how we see acute pain. And chronic pain, again, because there's a persistent pain, we think there's a persistent pain is created due to persistent injury, or healed or otherwise, and which creates persistent disability, and which creates persistent distress. This is how we view pain. That is how management of pain is handled. So this is neurobiologically inaccurate. To me, 100% inaccurate. It's not slightly inaccurate. It's 100% inaccurate. So it's a better way to understand the science behind pain. So we have been working on this narrative for about 5 years, and this is a narrative that we use in the clinic to make ordinary people understand what pain is. So we think of pain as created at the local site, but the acute injury has no ability to create pain at the site of injury. You really understand that acute injury or any injury has no capability to create pain at the site of pain. It creates noxious signals, which kind of translate into common language means threatening signals. Signals that indicate threat. And it could be physical, chemical, inflammatory, and nerve-ending changes. All this has to go up to the brain, and the brain assesses the threat of danger, and the brain decides to make pain. Right? This decision to make pain is not really driven by the severity of the injury, but by context of the injury, or the severity of the threat assessed by the brain, which is contextual. So, for example, if you talk to military people, you heard hundreds of stories where people get shot and keep on fighting without feeling much pain. They pain when they come to the base. Why? Because the threat of war is more than the threat of injury, so the brain shuts down pain and disability because it impedes survival. When the threat of injury, if it's severely injured, doesn't matter what the war is, what battle is going on, they are in severe suffering. But when people who are doing well on the war front after the injury comes to the base, the threat of war is reduced and the threat of injury picks up, and they start feeling pain and disability. So that's a pretty common story in many circles, which is very easy to understand. So the pain created is injury, noxious signals, threat, which is contextual, and which creates, then brain decides to generate pain, but the pain is mostly experienced in relation to the injury, centered on the site of injury. So because of this, most people think the pain created here, but pain is always a brain created experience. So the acute injury. So other conception regarding pain is just an indicator of injury. If you really think about evolutionarily, what is the advantage for our body to an indicator of injury 100 years back when there was no effective medical treatment? It can be that. The body's intention of putting in pain cannot be, just to indicate injury. So pain is part of a larger healing response. What I mean by that? So look at it. Pain never happens alone. I don't know whether the slide is clear to you. It happens with a lot of things. Negative effect, anxiety, anger, irritability. to lethargy, anorexia, immobilization, libido, disinterest in things, isolation, social withdrawal, sleep disorders, cognitive changes, depression, dysphoria, hedonia, disability. So pain comes in association with a lot of things. When somebody tells you they have pain, they are saying they have a little bit of all of these things too. This is, which one and to what extent varies between different people. So where you see this package of things, pain with all these things. So when you get flu, you get all of these things without, having an injury. So the purpose of such a response is to keep you in bed, rest, so you don't waste energy on other things like hunting for food, doing other pleasurable things which are not necessary for survival, and allot all your energy and resources for healing, which promotes healing and assures survival. So it's a small, although it predominates your experience, pain is just a small part of the behavioral suite of response that promotes healing and survival. Also, as part of a protection response, right? As the protection, if you touch a hard plate when you're a kid, you're never going to touch a hard plate again. You see a hard plate, you feel the pain in your hands. So it protects you from the perceived harm or the possibility of harm. For example, if you or pain protects you from things that might impede healing and survival. So, for example, if you had a knee fracture, the pain not allow you to put your foot on the ground because it might impede with the healing. And to have a proper knee healing is important for survival. So, what happens with acute injury, noxious signals? So what happens with this is as injury physically heals, the healing response and the need for healing response and protection response goes away. So pain, suffering, and disability disappear and diminish and disappear. So it's a typical healing that happens. So in either injury, which elicits the protect healing response, creates the suffering and disability. And physically, is the injury physically heals, the need for it disappears. So the pain, suffering, and disability disappears. So what injuries? So what about chronic pain, right? So most injuries, non-fatal injuries, heal within 3 to 6 months. What's so cocky about it? That is, surgeons make a living. If you cut open a belly, if you cut open a chest, or if you cut open even a brain, they sew it up. It heals in most people. It doesn't heal properly, or heals in a way. Even if the injury persists in a deleterious way, you don't survive. People don't survive. So there is no need for healing and protection response after the body adapts to healing. In a proportion of patients, the healing and protection response persists despite healing. This is the classic definition of chronic pain. So, is the persistence of pain after the usual time of healing of most injuries. If it injury, something else should be driving the chronic pain, right? So the neurobiological literature suggests, it's a threatened brain. There are more sophisticated scientific language for this, but it's a threatened brain. There is no injury involved in driving the chronic pain. So what a threatened brain takes is a non-noxious stimulus. That's a non-threatening stimulus, like bending a little forward in a chronic back pain patient. A non-threatening stimulus and interprets the threatening or possible of causing harm in the future and triggers the healing and protection response, and which results in persistent pain, suffering, and disability. But even though pain is still a central process, the pain is experienced